Hello, my dear friends. A very warm welcome to all of you in this NEET PG 2024 guest paper section. We will not only try to guess the question for your upcoming NEET PG exam, but also try to gain command over the topics from which questions are more expected to come. So let's start with this first question based on Anemia Mukt Bharat, on the treatment which will be given to a female, and she is an adult female with HB equal to 13. So what do you think is the treatment that should be given? First thing is that in Anemia Mukt Bharat, when we give tablet to adult, it is red color tablet, and red color tablet is given once a week in adult female for prevention of anemia, and this female is non-anemic. So for non-anemic female, we give the same treatment which is under Anemia Mukt Bharat, and that is answer C. But if I change the question and I make the HB equal to, let's say, 9 for adult female, then what will be the treatment? Then the treatment will be 2 IFA tablet, and the dose will be the same, 60 milligram iron and 500 microgram folic acid, and this tablet will be given twice a day. And this treatment will remain same whether it's adult female or pregnant female. In both of them, we are going to give the same treatment. Now, if in this question I make it, let's say, change the question and make it HB equal to 9, adult female of more than 34-week period of gestation. So now she is coming very late in pregnancy. We cannot wait too much for iron tablet. Ideal treatment will be, of course, again 2 IFA tablet of the same dose which is written above, 60 and 500, 2 IFA tablet per day. But in this cases, if she is not responding to IFA tablet, then we can shift to IV iron sucrose or IM ferric carboxy maltose. So if she is not responding till 34 week, then give IV iron sucrose or IM ferric carboxy maltose, FCM. So basically, this female, if she is having mild anemia, in case of mild anemia, we start with 2 IFA tablet per day. But if a patient come with moderate anemia, then we give IV iron sucrose or IM ferric carboxy maltose. And do remember, whenever we give IV iron sucrose or ferric carboxy maltose, we do not give IFA tablet with them. So either IV IM dose will be given or iron tablet, one of them. And if the female is coming with HB less than 7, severe anemia, then in that case, we will directly go for blood transfusion if female is coming late in pregnancy, let's say more than 34 week. So these are the treatment. I hope you will remember. And do remember this 3 more point about Anemia Mukt Bharat. First thing is, the target of Anemia Mukt Bharat is reduction of 3% anemia each year. The target of Poshan Abhiyan is reduction of malnutrition 2% each year. Second thing is, in Anemia Mukt Bharat, the 6x6x6 strategy is there. So the first 6 are the beneficiary who will get the benefit. The second 6 are the benefit which will be given, and benefit can also be called as interventions. Better word to say it as interventions. And last 6 are the institutional mechanism by which we will give this benefit. So they can ask which of the following is not a benefit of Anemia Mukt Bharat program. So do remember the 6 benefit. What are those? One is the iron folic acid tablet. Second is the, of course, second is the albendazole, deworming. Then there is BCC, behavior change communication. What does it mean? Solid body, smart mind. The logo of that program, we will say to the mother that if you will take the tablet, the child will be smart and come first in the class. She will take it. and if we are giving it to the child, we will say you will be able to fight with all the children of the street, and therefore you will have solid body by eating iron tablet. So when we say solid body, smart mind, it can change their behavior. So that is the third benefit, behavior change communication, which is the logo of the program also, solid body, smart mind. The fourth benefit is that we also have to focus on other cause of anemia as well, which are malaria, filariasis, and thalassemias. The fifth benefit is we will focus on food fortification. We will try to add folic acid or iron in salt and other food. And the sixth benefit is that we will do digital HB measurement and follow up of pregnancy. So when we do follow up of pregnancy, this follow up is usually done with the help of Anmol software. This Anmol software is given to ANM, auxiliary nurse midwife, which is same as health worker female. And this Anmol is a tablet based software. That's why the full form is Anmol. And Anmol means ANM online. So it is tablet based software. The logo of this program will have green color mother, green color child. And this program, this Anmol software is for data entry and follow up. So these are the 6 advantages. I hope you will remember it. Now, coming to the recommended daily intake of iodine in pregnancy, it is 250 microgram. 150 microgram is for adolescent. A lot of question can come from this dietary intake. Last NEET exam also you have seen a lot of question was from nutrition. So we should be rock solid with this topic of nutrition. First thing is, in pregnancy, the dose of calcium is 1000 milligram, and this calcium dose increases. Only one nutrient which become more in lactation is of course calcium, and it become 1200 milligram, which is also the dose for old age, 1200 milligram per day. When it comes to vitamin D is same for everyone, 600 international unit. When it comes to iron, iron is around 23 milligram per day in pregnancy needed, and it is around 27 needed in young adult female who are menstruating. So these are some of the requirement. Plus you should also need remember the extra kilocalorie, which is during pregnancy is 350 kilocalorie extra, but during lactation it's 600 kilocalorie extra. Two more questions frequently asked is estimated average requirement fulfill the need of 50% population, whereas recommended dietary allowance fulfill the need of 97.5% population. So usually we read about recommended dietary allowance. Now let's come to the next question. Which of the following statement is true about net protein utilization, NPU? So if you know the answer, please guess. I would be more happy to see your answer coming. It's very simple thing. Net protein utilization, we will write the protein or nitrogen retained, utilized above. And utilized means retained. And we will divide it by the nitrogen which is present in food. And we will multiply it by 100 to get the answer in percentage. So what is NPU? NPU is the nitrogen or protein or nitrogen retained by protein present in food. And it is maximum for egg, of course, coming out to be 96. That means, let's say, whenever you go to let's say I went to a gym, and they said in every gym that eat egg white. So let's say in the first day of gym, I eat 17 egg white, and I ate so much egg white that I started looking like an egg myself. So every egg give around 6 gram of protein. 17 egg will give me around 100 gram of protein. Out of that 100 gram of protein, which will be present in 17 egg, my body will utilize 96 gram and only 4 gram will go away. So protein which will be utilized in muscle making and enzyme will be 96 out of that 100. That's why egg is the best quality protein, because it has maximum NPU. But do remember there is one more formula for NPU. NPU is also written as digestibility coefficient into biological value by 100. These two are the different formulas. Plus egg is best quality protein, but of course I hope you know soya bean have maximum amount of protein and fish has maximum protein energy ratio. Okay, protein energy ratio means if I eat a big fish, let's say which give me 1000 kilocalorie energy, out of that 1000 kilocalorie energy, 80% will be coming from protein. So protein energy ratio of fish is maximum 80%. And in soybean, I hope you know, there is 44 gram of protein per 100 gram of soybean. Now, fish is deficient in which of the following nutrient? Fish is deficient in iron. Human milk or mother milk is deficient in vitamin K. And egg is deficient in vitamin C. And of course, vitamin C richest source will be Indian gooseberry or amla. Not hasim amla, amla, gooseberry. Second thing they can ask you is which protein protect us from myocardial infarction? Well, not protein, which fatty acid, that is omega-3 fatty acid, this prevent from MI. And which is the most essential fatty acid? Is it linoleic or linolenic? So the answer will be linoleic acid. This is the first essential fatty acid. Second is linolenic acid. How will you remember it? Very simple. If there is 2N, it is second number. In linolenic, there is 2N, so it is second number. Linoleic, there is 1N, so it is first number. Okay. Third essential fatty acid is arachidonic acid. In WHO Road to Health chart, upper and lower limit represent which two things? A lot of questions come from WHO health chart. Do remember this. In the growth chart, the first line is 50% of weight of boy. And the second line, which is at -2 standard deviation or -2 Z score, this is third percentile for girl. Why? Because we know between +-2 standard deviation, 95% value lie. So that means 5% value go outside +-2. And if 5% is, if 5% is outside, 95% is between -2 to +2. So 5% is outside. If 5% is outside, those 5% will not be in one side. There will be 2.5% here, 2.5% here. So below -2 standard deviation, 2.5 percentile people are there, and we cannot cut a person into half. So roughly 2.5 percentile can be called as third percentile. So that's why -2 standard deviation is at third percentile weight for girl, and any children who are between it, they are called healthy. They are said that they are following road to health. Second question which came from here is, what is between second and third line? Second and third line will have moderate malnutrition, and below this there is severe malnutrition. Now, a lot of questions come from it. As I said, the first question which come in from it is, in Anganwadi, which growth chart is plotted? So if you are plotting it in Anganwadi, it is weight for age which is plotted in Anganwadi. And in Anganwadi, what is the age up to which children goes? Children do not go only up to 5 years, they go up to 6 years in Anganwadi. 6 years is the age group. Weight for age is plotted. And do remember this thing, that let's say in exam they gave that -1.7 is weight for height. Okay, -2.5 Z or standard deviation is weight for age, and -3 Z is height for age. So this child is of which category? Is it moderate malnutrition? Is it acute malnutrition or chronic malnutrition? Like that they can ask. It was a recent question in INICT also. So see, I hope you all know that if there is low weight for age, if it is low, it can be acute or chronic, both together or any one, and low weight for age can be due to both of the reason. When it comes to weight for height, if weight for height is low, it means there is acute malnutrition. It means height is good, weight is less. So there is nothing like chronic problem. The problem may be in last 1 month the child have diarrhea or some infection leading to acute loss of weight as compared to height. Height अच्छी है, weight कम हो गया, सूख गया है बंदा. It is known as wasting. The child has gone wasting. Okay. And if height for age is low, we all know height for age low means stunting, and height for age low indicate chronic malnutrition. So according to weight for height, it is coming minus 1.7. Minus 1.7 means it is between 50 percentile to minus 2. It is in this part. This is 50 percentile and this is minus 2. So minus 1.7 will be somewhere. It means the child is normal when it comes to weight for height. So according to weight for height, child is normal. Therefore, there is no acute malnutrition. And acute malnutrition is gone. So which malnutrition this child is suffering from? Because he is not having acute malnutrition, therefore the only malnutrition left will be chronic malnutrition. Because you can see here also height for age is less, so less height for age indicate chronic malnutrition anyway. Weight for age indicate both acute and chronic, but because acute we have ruled out, so the option left will be chronic malnutrition, and this child will be having chronic malnutrition. And do remember one more thing, that what is the definition of severe acute malnutrition? They ask again and again. Sam should have weight for height less than 3 standard deviation, or less than minus 3 standard deviation. Second thing, that mid-arm circumference should be less than 11.5 centimeter. This is what comes red color in Sakir tape. And then there should be visible wasting or edema. If these 3 criteria is being followed, we call it severe acute malnutrition. Now, in Anganwadi growth chart, as I said, we draw weight for age. But which criteria, which guideline is being followed for it? That is known as MGRS standard. MGRS stand for Multicentric Growth Research Study. I still remember that when I joined my MBBS in 2006 in Aligarh Muslim University, at that time, India don't used to follow WHO growth chart because it was based on American children, and Indian children used to come malnourished on it. So then what WHO did was, they choose children from 6 countries, and based on their average, they made a new growth chart. So then while doing my PG at AIMS, we were following WHO growth chart. So what are those 6 countries? We can remember them by the mnemonic BAUGNI. Brazil, Oman, UK, Ghana, Nigeria, and India. These are the 6 countries. And that's why this is known as multicentric growth research study, because a lot of country children are included. This is based on MGRS standard. Now, total number of live births per 1,000 women in reproductive age group is known as. This is a common googly type of question. As soon as the students see total number, they tick total fertility rate. But total fertility rate simply means total live birth per female. If 1,000 word you will add, then it will become general fertility rate. So general fertility rate is total live birth per 1,000 women, and total live birth per female is TFR. And India's target TFR is 2.1. We want that every female in India should produce 2 and 0.1 children. How it will be 0.1? Because it's always measured for a group. And so some will produce 3 children, some will produce 1, some will produce 5. Average will be 2.1. And if 2.1 children are produced, out of them some will die, and finally it will come 2 child per female. So the target is 2.1, which India has achieved. So population growth is not a problem for us. So these 2, TFR and GFR, will never be the answer if in the question they have used the word girl. If girl word is being used, then answer will either be GRR or NRR. GRR, of course, stands for gross reproduction rate, which is girl live birth per female. Birth per female. And NRR is also girl child per female, but this time in NRR, we will subtract those girl child who died before 15 years of age. So we will considering age specific mortality rate. Okay. So what I'm trying to say here is, in the question, if you find girl child, these 2, TFR and GFR, are ruled out. And out of GRR and NRR, how will you choose? If you found in the question the word mortality, then answer mortality and girl together, then answer will be NRR. But if you find only girl live birth per female, answer will be GRR. I hope you will be able to differentiate these four things. Do remember, if we want 2 child per couple, NRR should be equal to 1 and couple protection rate should be equal to 60%. Then there will be 2 child per couple, hum do hamare do. Okay, which is our target. Now, and what is the current couple protection rate of India? It is 66%. So some energetic doctors like you have given condom and contraceptive to 6% more couple. So should you take it down back? No, na. But it means that the population growth is no more a problem for India. Now let's come to the expanding stages of population growth, and they can ask in which phases growth rate is birth rate is high. So in first and second phase, which is high stationary and early expanding, in these two phases, growth rate, birth rate is, in both these phases, birth rate is high and high. And in the high stationary, birth rate, death rate, both are high. That's why the number of people who were taking birth, they were dying also at equal stage. That's why the population is almost stationary. India was in this phase before 1930. Then we went into early expanding when birth rate was still high, but death rate start decreasing. And then India went into late expanding. So this was the question. If you can guess the answer, please guess it. Will be waiting for your answer. Very good, future doctor Utkarsh Utpal. Thank you for replying. Dr. G also is there. So when it comes to late expanding means the birth rate is start decreasing, and death rate, it's something which decreases further. India is right now in this phase. So they are asking the question about late expanding. Which one will be correct for late expanding? Death rate is not same. Death rate decreases further. So expanding means always expanding means birth rate is more than death rate. Only then population will expand. So birth rate is less than death rate. This is only in the declining phase. The last phase we will discuss further. Birth rate decline, death rate remains same. We can say that, but better answer will be that birth rate is stationary. That is also not correct. Birth rate becomes stationary in this fourth phase when we have low stationary. In low stationary, birth rate and death rate both are low. So the method to remember this is, we only have to remember the second and third part. This part only you have to remember. First and fourth is high and low stationary. So both birth rate, death rate are high and low. And the last is declining. So in declining, birth rate became less than death rate. Birth rate become very low and death rate remain low. So option 4 is for declining, which is saying birth rate is less, birth rate is less than death rate, that is declining. In declining phase, growth rate become negative, and most of the European countries are in this phase of declining. But let's go one by one. First option is birth rate is stationary, death rate continue to fall. That is early expanding. In early expanding, birth rate is high and death rate continue to fall. Death rate decline more than birth rate. And birth rate is also declining in second phase, but death rate decreases further. Okay. So death rate decline more than birth rate, and then the country will be having increasing population, growth rate will be positive. So this is the answer for late expanding. Death rate decline more than birth rate, that is known as late expanding. Okay, birth rate decline more than death rate. Okay, and death rate remains so same, that is not corresponding to any phase as such. But do remember, late expanding is, you have to remember, late expanding means death rate decreases further, birth rate start decreasing. So that means death rate is declining more than the birth rate, because birth rate has just right now started decreasing. And India is right now in this phase, but in next 10 years, India will go into low stationary, and China, as you all must be knowing, has already gone into decline. Last year in China, the people whose birth rate was less than the death rate, and the people who took birth were less than died in China also. So these are the 5 phases. Do remember 2 more questions from these phases. They ask that which phase has maximum growth rate. Maximum growth rate is in late half of early expanding, late half of second phase. What is the second phase? Early expanding. Which phase has growth rate start decreasing from which phase? So growth rate start decreasing from early half of third phase. Early half of third phase growth rate start decreasing. And which has negative growth rate? Negative growth rate is in phase 5th. So in which 2 phases birth rate is high, first and second? In first, second, you can see birth rate is high. Okay, so these are some of the questions from the phases and demographic indicator. Do remember, which of the following is best for determining threshold? Threshold means cutoff. When we want to determine cutoff for a diagnostic test, we use receiver operating curve. In receiver operating curve, you can get an image-based question like this. And do remember, the curve with highest slope, this is taken as the cutoff. And this slope which is going at 45-degree angle, this is useless. This is useless, 45-degree, because we are in receiver operating curve. On y-axis, we have true positive rate or sensitivity, and on x-axis, we have false positive rate or specificity, 1 minus specificity. So if it is at 45-degree, it's a useless cutoff, but the slope with highest, the curve with highest slope is representing maximum area of the curve, is representing maximum positive likelihood ratio, and that is telling us the ideal cutoff for a diagnostic test. So a receiver operating curve tells us about the cutoff, and it also compare between 2 tests, that which test is better. Sometime they can give you an image-based question from Kaplan-Meier plot also. Kaplan-Meier plot will have this step ladder pattern. And nowadays they are asking that in a Kaplan-Meier plot, which tells about the survival time. Let's say you are trying to compare that unilateral knee transplant is better or bilateral knee transplant. So suppose this one is for unilateral, this one for bilateral. 100 patient went through both of them in 2 year, 4 year, 6 year, 8 year, 10 year. We are comparing the survival. So it's quite obvious that unilateral people are surviving more. So this is Kaplan-Meier survival plot, which help us to know the survival time of 2 intervention. And the curve which is on the rightmost side, this curve will have better survival. Okay, the curve which is right hand side, because here we are writing survival time. So this curve will have more survival time. So Kaplan-Meier survival plot, what is the use? To compare between 2 intervention. ROC curve, what is the use? To know cutoff for a test and to compare between 2 screening tests, that urine sugar is better or blood sugar is better, like that. So that will be Kaplan-Meier survival plot. One more plot you can get is the plot of tracking phenomena. You can get this type of plot. And this question has came in NEET 2023 also, that a group of people, their BP was taken at 10 year of age, then at more after, let's say, after 30 year, 40 year, again their BP was taken, and it was found that the people with lesser BP at the beginning also have lesser BP at the end. So this type of plot will be there in tracking phenomena. So these 3 plot can come from image-based question. Do remember the concept, that if BP is more at younger age, it will remain higher at older age also. It's like BP is tracking the person. So that is tracking phenomena. And then one more thing they can ask is from the rule of half. In the rule of half, the only question they usually ask is, what is the innermost circle telling us? So the innermost circle tells us about what is the number of people who are having adequate control. Patient having adequate control is innermost circle. Do remember these plot and circles. They do ask. For RCT, to assess dating in adolescent, a study was done by selecting random schools, then random classes, then random section, and then random student. This is an example of which type of sampling. Usually we miss this concept of sampling. So let's have 2-3 questions which will clear this concept. This type of sampling is multi-stage. Suppose you want to know that in Delhi how many students are going for dating in their 11th 12th class. So from the Delhi you will choose 3 areas. In those 3 areas you will choose 2 colony each areas, and from each colony you will choose, let's say, 4 schools. From each school you will choose 10 students, and you will do the study on those 10 students from 4 school, from 2 colony, from 3 area. This will be your sample size, and you will say, let's say in this 10 student of 4 school, it came that 60% students are going on date in 11th 12th class. So you will say that in Delhi 60% students go date in 11th 12th class. Whatever you get data from this sample, you will apply it on the whole population. So this type of question will be multi-stage, and they can give you an image-based question also, big image, then small they are taking. That is multi-stage sampling. Okay, this is used for collection of data not only in India, NFHS, DLHS, but also in UK, USA. All the data are mostly collected by this manner, and we take a small sample and then we collect data from that. But if it is cluster sampling, and now let's revise this sampling, the 5 techniques which are there. Multi-stage, we are taking multiple cluster again and again. That's why multi-stage is also known as multiple cluster sampling. Because what is Delhi? Cluster of people. Then what is area? Again cluster, again cluster. So we are choosing cluster again and again. That is multiple cluster. But if they ask only cluster sampling will have people from common origin. For example, in WHO immunization study, suppose I want to compare that in Delhi immunization rate is better or in Uganda it is better. Okay, Uganda, don't call me Uganda, it's a real country name. Okay, so everywhere if we want to compare the immunization status, the pattern is same. We will choose 7 children from 30 villages in India, different villages, and we will choose 7 children from 30 different villages in Uganda. So the total sample size will be 210. We will take the history of these 210 children in Delhi and in Uganda also, and then we will compare who have better immunization status. So these all 7 children are coming from common origin, from the same village now. That's why it is example of cluster sampling. And because they are coming from same origin, so their variation is less. They are mostly similar. And because they are similar, so cluster sampling have greater sample size as compared to simple random sampling. Greater sample size because they are having less variation. They are common, similar. So we need to choose more people when we are doing cluster sampling and less people when we are doing simple random sampling. There is a simple formula also that when we want to know the sample size for cluster sampling, in cluster sampling, let's say you choose 210 sample size. Then we have one design effect, which is always more than 1. And we multiply it with sample size for simple random sampling. And if I want to know the immunization status, I can randomly choose 70 people from different parts of India also. Rather than choosing 7 people from 30 village, I can randomly choose 70. And then design effect will be 3, and finally it will come to 10. So you can see the sample size of cluster random sampling is always more than sample size of simple random sampling. That was the question. What is true about cluster sampling? Sample size is not same. It is more. Sample size for, because we are asking in this question true about cluster sampling except. So sample size is always more in cluster sampling as compared to simple random sampling. And cluster sampling is of course done by 2 stage. It is cheaper and it can have higher sampling error because children whom we are selecting are from the same village, so it can have more sampling error also. but the sample size of cluster is always more. The third type of sampling is simple random sampling. This is best for homogeneous population. Suppose I want to know that how many, let's say, how many web series or Netflix, how many Insta reel students are watching per day. So to know this thing, that how many Insta reel you are watching on an average per day, I can randomly choose any 100 student from any college, and it doesn't matter whether you are boy or girl, because for Instagram, watching Instagram reel, boy, girl, both are same student. So you are homogeneous when it comes to watching Instagram reel, you are similar to each other. So whenever we are choosing similar population, we do simple random sampling. It is done by lottery method or by random number generator software. The fourth type of sampling is systematic random sampling. So in systematic random sampling, we choose every nth student. Let's say if I want to know that villagers are using condoms or not, what do you think? They are using it or not? So if I want to know it, I can do the interview of every first and fourth house of the village are being interviewed about it. So if we are following a system that we are choosing first and then fourth, that is systematic random sampling, okay, are selected for interview, then this question has already been asked also, then this type is systematic random sampling. And the last sampling is, the fifth type of sampling is stratified random sampling. Stratified means we will divide the population into two halves and then choose equal number from the two halves. And stratified is best for heterogeneous population. For example, this question has been asked that, let's say you want to know the dietary pattern of people living in a population, and of course their diet is different depending on their religion, also depending on their let's say Jain are not eating, mostly non-eating non-veg mostly, and so based on this, if you are dividing the population and then choosing equal number, that is a stratified random sampling. Strata means layer, so you are creating layer and then choosing stratified random sampling. Let's do this question, it will clarify it further. If study subjects are selected according to the potential factor that will influence the outcome of the study, then the sampling is stratified random sampling. For example, let's take an example for this. In my PG, I was doing a study whether you want to donate your organ or not. And in one question was whether our religion promote organ donation or not. And to know this question, I need representation from each religion. But in my Haryana population where I was doing this study, only 2% were Muslim. So based on 20 people opinion, I cannot say whether Islam promote organ donation or not. So what I should have done, I started doing simple random and choose 1,000 people from the villages, because I thought every villager is equal. But according to the question, whether your religion promote organ donation or not, they were heterogeneous, different from each other. So rather than choosing 1,000 people randomly, what I should have done is, I should have pre-decided that I will choose 400 people from Hindu religion, 400 from Islam, 400 from Sikh. And then I should have asked the question that does your religion promote organ donation or not? Why I should have divided them into 400, 400, 400? Because they were different based on their religion, and religion were affecting my question that whether religion is increasing organ donation or not. So when people are different, we do stratified random sampling. When people are uniform, same, homogeneous, then we do simple random sampling. Okay, let's summarize this 5 sampling together. Suppose I want to choose 10 people out of 100 which are attending this class for a party after the class. And suppose is the main word. So what I can do is I can choose you based on your name. Randomly 100 people name came, I will choose any 10 chit, and based on chit I will do, that is simple random. Second thing I can do is I can divide the class into boys and girl. I will choose 5 from boys, 5 from girl, so that they can also have some setting or love during that party. So I am dividing you into boy, girl, and then choosing 5, 5, that is stratified random sampling. And if I am choosing every 7th student, 1, 2, 3, 4, 5, 6, 7, then 8, 9, 10, then again 7 student. That is systematic random sampling. And if I am choosing every student who come from Delhi, 4 students from Delhi, 4 students from UP, like that cluster I am choosing, that is cluster random sampling. Okay, so these are the sampling techniques and the question coming from it. Now let's see this photo. I hope this is clear to this. They are asking, what does potential point A, B, C, D denote? So when it is a stage of susceptibility, at this point, the symptom has not started, pathological change has not started. Pathological change start at point A. Then after pathological change start, then there is subclinical disease which cannot be detected. So in this part, there is, we can say, no. Actually, this point A is when the agent entered into the body. Agent entry is A. After agent entry, pathological changes start, that is point B. But symptom are yet not coming. So when the symptom come at point C, and usually we start diagnosis at clinical disease. So D is stage usual time of diagnosis. So what is C? C is the onset of symptom. A similar question can come from lead time bias. They can give you 5 point A, B, C, D, E. A is the entry of pathogen. B is the earliest symptom which can come. C is the critical time at which cancer start spreading, critical point of spread of cancer. D is the point of diagnostic test. And E is the point of death. So they can ask, what does BD represent or BC represent? What does it represent? So between A to B, earliest detection and entry, the disease is hidden. So A to B is the latent period in which the disease is hidden. Then the duration between earliest detection of symptom and usual diagnostic test, this is the definition of lead time. So what is lead time? The time gap between early detection and usual diagnostic test. But is there any point of making the screening test or making the diagnosis after spread of cancer? No, na. So what is this B to C? B to C is that point in which we should do the screening test. Only then we can do some intervention and save the life of patient. So screening time is B to C. And in this example, is lead time bias present or absent? So here, between B to C, we can do some surgery, some intervention, and we can save the life of patient. So this lead time is not absolutely useless. Half of that lead time between B to C is useful in improving the survival of patient. So in this example, lead time bias is absent. Lead time bias is present only if critical point of diagnosis is before earliest screening test or earliest detection. And it's not earliest symptom, it's earliest detection. If earliest detection, of course symptom help us in detection, but earliest detection is at point B. So if earliest detection is before spread, then lead time bias is absent. Like here, lead time bias is absent, because now this lead time can be used in improving survival of the patient. Okay. Now let's come to this question on direct and indirect standardization. Question is that when do we do direct standardization? Is it used to compare the mortality rate between two countries because of the difference in their age distribution? Let me explain direct and indirect standardization. Suppose our friend Vishal Thakur, who correctly said BD is the lead time, is in class 4th. And this 4th class, Vishal Thakur had a fight with 12th class person. So will Vishal go directly and fight with 12th class, or will he take help of other friend and then go and fight? Let's say, so if 4th class is fighting with 12th class, probably he will take the help and then go and fight with the 12th class person. So that is indirect standardization, because there is a small population or a small class student who is trying to fight with a large population. Okay, but if let's say Vishal is in class 12th and he is having a fight with 12th class student only, then they both are at the same age level, they both are big enough to fight directly. So 12th and 12th class will fight directly, but 4th and 12th class will fight indirectly. So whenever we want to compare the death rate of two large population, and like 12th and 12th, for example, you want to compare the death rate of Japan with India. In India, the death rate is 7.2 per thousand. In Japan, the death rate is 11.1 per thousand. So if you compare the crude death rate of India with Japan, it will look like India has very less death and Japan should learn from India. But is it a correct picture? No. Why we are getting this wrong type of comparison? Because in India, young population is there, but in Japan, more than 26% people are old, more than 65 years. So due to old age, their death rate is 11.1 more. So we cannot compare India with Japan like that. How we can compare? We can compare 0 to 60 year death rate, age specific death rate of Indian between 0 to 60 year with Japanese 0 to 60 year age specific death rate. And we will compare 0 to 5 year how many Indian die, 5 to 10 how many Indian die, and similarly we will compare for 0 to 5 how many Japanese die, 5 to 10 how many Japanese die. Like that we can calculate for 0 to 60 year. So if we will calculate their age specific death rate for each 5-year age group from 0 to 60 year, then the correct picture will come that in India it is around 5 per thousand, but in Japan it is only 2 per thousand. So the correct picture will come only if we measure the death in the same age group. So what is the use of why direct standardization is done? Because India and Japan are different from each other based on their age distribution. In India, more young people are there. In Japan, more old people are there. So due to age distribution difference, they cannot be compared. So we use direct standardization where we compare the age specific death rate of these two large population. Okay. So do remember, when do we do direct standardization? To compare death rate of two large standardized population. Like Indian population is standardized, Japanese population is standardized. Standardized simply means that population about which we know that in any 5-year age group how many people die. And so they are standardized because we know about them. They are having some standard. Like we say, this girl is standard, this boy is standard. And a boy standard means he will not say rough word like pad, hug, mooth, like that. We will be knowing something about that boy. That's why it is standard. So why this national population are standard? Because we are knowing that in national population how many people will die in any 5-year age group. So when we compare death rate of two large standardized population, we use direct standardization. What is the use of indirect standardization? First thing is, they ask again and again that in indirect standardization, what is the formula of standardized mortality rate? It is observed death by expected death into 100. Indirect standardization is done to get fund for any population which are oppressed and having more death than the national population. Let's say you want to help the street children population of your state. So you can call all the hospital and ask how many children in 10 to 15 year age group out of 1,000 general children who are working on street, how many died in 1 year? So out of 1,000 10 to 15 year street children, how many died in 1 year? And suppose you got that out of 1,000, 30 died. So this 30 data you collected by calling all the hospital. You observed it. You called and then collected the data. But what is the expected death in Indian children? Expected death is 3 deaths out of 1,000 normal Indian children who are not working on street. Normal Indian children. So expected is 3, observed is 30. So SMR will come out as 30 by 3 into 100, है ना? So it will be 10 into 100. So let's say you are a student who is doing this research in Rajasthan. So you can go to Mr. Bhajanlal and you can say, hey Bhajanwa, give me this fund to prevent the death in street children, because observed death in street children is 10 times more than expected death. And he may not give you fund. So then you can say that give me the fund because the standardized mortality rate is 1,000 in street children as compared to normal children of Rajasthan. So that's why we multiply by 100 to magnify the data 100 times. So why we are doing indirect standardization, you can understand. There is a small population, 4th class population of street children, whom we are comparing with 12th class big population of the national data and a big national Indian population. So whenever we compare small with large, it is indirect. Large with large, direct. So direct standardization is done because the age distribution is different. And when do we find out standardized mortality rate, SMR? So SMR is found when death rate of a population is adjusted to standard age distribution. Are you understanding this point, this question? This is a PYQ, we should know about it. When we do SMR, when we find death rate of a population, which population? Street children population, let's say. This is observed death which we found for a population. And we adjusted to standard age distribution. What is the standard age distribution? It is in the national population, the age distribution is standard. And so we are comparing observed with expected, multiplying by 100, that is standardized mortality rate, which is one of the best mortality indicator. So do remember, direct is done, direct standardization is done because there is different in age distribution, and indirect is done because death rate of observed small population, non-standardized population is less than death rate of large, is more than, and this is different. Observed death is different as compared to the death rate of large expected death in a standardized population like national population. So when we compare observed with expected, this is indirect standardization. Okay, now let's go to the next topic. I hope direct indirect is clear. Which of the following is not true for incubation period? This is a question which you must should answer. Why do we need incubation period? Do we need it for quarantine, for isolation, or do we need to prevent disease in contact? Which is not true. Not true for incubation period. So isolation is something which is done on patient with disease. Disease patient are isolated, and they are isolated till period of infectivity, till they can infect other. But quarantine is done on persons suspected of carrying infection. Suspected of carrying infection, and this is done till incubation period. So incubation period is needed for quarantine and is needed to prevent disease in other people, is needed for secondary attack and coincident, but it is not needed for isolation. Isolation is done by period of infectivity. And I hope this concept is clear to you. I'm not going detail of it, but do remember that quarantine and isolation both are example of primary level of prevention, because both are done to prevent other people who are at risk of getting infected. And quarantine isolation are done to prevent at risk population, and primary level is done when the risk is there, disease is absent. So that's why both are example of primary level. Now, next question is, in a population of 5,000 people, 500 are already myopic on January 1, 2011. Number of new myopic case till December 31 is 9. Calculate incidence. So the incidence, which is same as cumulative incidence, and incidence or cumulative incidence is same thing. It simply means how many total new cases are there divided by total susceptible population. Susceptible means those who are at risk of getting infected. So here total new case are 9. And how many people are susceptible? Total population was 5,000. But out of that 5,000, 500 are already myopic. So we will subtract 500 from it, because those who have already myopia, they cannot have myopia again. So we will subtract them, and we can multiply it by 100 to get the answer in percentage, which is there, and just solve it out and it will be the answer. So it will come out 9 by 4,500, 4,500 into 100. So this 20 will cancel out. 9 by 45. 9 by 45 means if you put 10, there is 9. I think the data is 90 here. But if it is 9 by 45, 9 by 45 means we have to put a one decimal. Decimal we will put, it will become 90 and 0.2. So it will come 0.2 percentage. Because 0.2 is not given in the option, that's why I was saying that in the original question it must be 90. And 90 by 45, if you do, it will come 2%. Okay. So this is the way to solve it. New case by total susceptible, and it will be solved. It's not a tough thing, so don't leave such question thinking it's a numerical so tough, not necessarily. What is the true thing? Nikhil, can you bring my phone? And there is cutoff for HDI which we need to discuss. And on the cutoff, there is a good question. There is a good image which I have taken from Park textbook to show you this question. It is not in that. Call karke dekh. Let's come to this question first. We will go back to the HDI cutoff and we will discuss it separately. There is a question that based on identification of ecological, cross-sectional, cohort and all such a study. So in a study in UK, an association was found between sale of anti-asthmatic drug and an increase in death due to side effect of anti-asthmatic. Which is this type of a study? Can you guess the study example? So in this study, no question is asked from anyone and there is only one group. If there is one group or one population, it is either ecological or cross-sectional. And in ecological study, we do not ask question from anyone. Like here, we are just collecting the data from hospital, because increase in death due to side effect, this is hospital data. And then we are correlating this hospital data with the data of sale of sale of anti-asthmatic drug. So this type of data obtaining from the marketing department, this type of data is population data. And whenever we correlate hospital data with population data, this study is ecological study. The other name of ecological study is correlational study. Because in correlational study, we correlate hospital data with population data. But in cross-sectional study, we ask question from every participant. That is why cross-sectional study is also known as prevalence study. Suppose I want to know that how many students are using Tinder. So I can ask this question to, let's say, 100 students, how many of you use Tinder? And I'm asking it from everyone, and I came to know that out of 100, let's say 60 are using Tinder. So 60 out of 100 become prevalence. Prevalence means old plus new case. They may be using it from a long time. They might have in the morning, they turned into mood and they downloaded it in the morning. They can be new case also. So new plus old case is prevalence. Cross-sectional study tell us about present moment prevalence. That is why one more name of cross-sectional study is snapshot study. Can you take picture in past or future? No. We can only take picture in present moment. That's why cross-sectional is done only in present moment, and this is a snapshot study, prevalence study. So ecological and cross-sectional done on one population or one group usually, and in ecological no question from anyone, in cross-sectional question from everyone. So this way you can decide those studies which are done on one population. Let's have one more example. They are saying that a study was conducted in 3 villages with 3 different water sources, and prevalence of typhoid carrier was studied in 3 villages. So they're just asking, taking some stool sample or blood sample, and they are just finding how many are carrier. So they are collecting data from everyone, and they are collecting data about present moment, not about past or future. So present study, as I said, is cross-sectional study, and anyway the prevalence word is written. Whenever prevalence is being found, it is cross-sectional study. So this type of study will be cross-sectional because question is asked from everyone. Now, when it comes to cohort and case control, usually in them there will be 2 groups or 2 population. In case control, do remember that the starting point will be case and control. That means starting point will have one group in which outcome is present, one group in which outcome is absent. Parinam present, parinam absent. And a reason outcome can also be disease present, absent when we start, that is case control. Outcome present, absent when we start, that is case control. And when will you call it cohort? Cohort will have exposure present and absent, karan present and absent. So if they say exposure or reason or risk factor or karan, the cause present absent, then that is cohort. But if they say outcome present absent, it becomes case control study. Now, this cohort which I am writing here is same as prospective cohort, because in cohort we go in future. So sometime they can give you this name. Cross cohort is also known as prospective cohort. This is also known as longitudinal cohort, and cohort can also be called as follow-up study because we do the follow-up and we go in future. And it is also known as incidence study because we are trying to know the new cases which will occur in future. So incidence means new case in future. So these are the other name, but do remember the most important name is cause to effect. We start with karan going to parinam. We start with risk factor going to the disease. So cause to effect study is cohort. But there are 2 other type of cohort. One is retrospective cohort, which is also known as historical cohort. And these days they are asking a lot of question on retrospective or historical cohort. Like they can give you this thing that there was a study done on urinary bladder cancer among the, let me create a good example for it to make it better. Suppose some of you studied very well and you got radiology branch, and after getting radiology branch you are giving a big party. In that party your neighbor came and said ki, why are you giving this big party? Don't you know that based on 10-year work record data, work record or written data, testicular cancer is 1.2 times more common in radiology staff as compared to other staff. So this line itself, that based on work record or written data, it indicate it is retrospective cohort or historical cohort. And let's say your neighbor came and said this thing that the risk is 1.2 times more, and 1.2 is not a big risk. Whenever relative risk or odds ratio is equal to 1, it means there is no risk. When it is 1.2, it is slight positive risk, and when it is less than 1, it is negative or protective factor. So whenever in the question you found work record or written data, it is retrospective cohort. Now suppose you took radiology, and after taking radiology you neglected that advice and you took radiology, and after taking radiology you did a follow-up study for next 3 years also, and you utilized past data also. So here, along with past written data, you are utilizing future follow-up of 3 years, both the things. So if you are doing both the things, then we can call it mixed cohort or ambispecative cohort or nested case control. 3 name. Okay. Why it is mixed? Because we are going in past and future both. Hemispective because we are going past and future both. Nested case control because the main effort is in cohort, and cohort is the main study in which data of past is inserted, nested, है ना. Cohort में case control ने घोंसला बना लिया है. There is a nested insertion of data of case control in cohort. So all these three can be written together as man. The mnemonic to remember it is RH positive man. RH goes backward, man can go forward, backward both. And RH positive man is there only then erythroblastosis fetalis will occur. So RH, when they give retrospective cohort historical, they will say work record data of past. When they say mixed ambespective nested, then they will use both the thing, past written data plus future follow up. Okay. So I hope you will be able to differentiate the different type of study that will come with this concept. Coming to the next study question, which of the following is the best study design to demonstrate relationship between cause and effect? If they use this line cause and effect, this is known as temporal association. Temporal association means cause precede effect. Sometimes they can also write this as natural history of disease, and they can ask which is the best study to know natural history of disease. And as soon as the students see history, they will take case control. But no, natural history means what is happening in the past. You go through that follow up and then you reach the future by, you did not ask the past history, but you did the follow up, and then you know the natural way by which the disease occurred. And like my younger sister used to have a lot of scooty accident. So to know the reality, I sit in her scooty and then I found that she's doing accident because her hand is small and brake is loose. How I know the reality? By doing the follow up, by sitting in her scooty, and then I know the reality. So it is cause precede effect, and a loose brake is occurring before accident. So cause precede effect is there, and we can know it by follow up only. So all these three are best known in cohort study. Now, why this question is so important? Because they can ask in Hill criteria of association, which is the strongest criteria. Answer is temporal association is the strongest criteria in Hill criteria of association. Okay. And do remember, in Hill criteria of association, sensitivity is not included. And there are total 9 criteria, out of which sensitivity is nothing. There is a specificity as a criteria, but not sensitivity. And in temporal, in which study we can go get the natural history best? In cohort study. But if they ask, let's say, best study to compare effect and outcome, and they give you the option of RCT, या clinical trial and cohort both. So then the answer will be RCT, because if you look at the evidence-based medicine, in evidence-based medicine, the first priority is given to meta-analysis, second to systematic review, third to RCT, and then the fourth to cohort. And after that, there is case control, cross-sectional, ecological, case series, case study, and then expert opinion. So it always start with meta-analysis, but then you can see RCT is above cohort in evidence-based medicine. So if they ask best study to compare effect and outcome, then RCT will be better. But if they ask best study to compare cause and effect, for cause and effect, cohort will be better. And if they ask the question, best study to compare congenital side effect of a new drug. So for congenital side effect, it is unethical to do RCT or cohort. And we cannot give it and then keep writing that today 3 children died, we should not have given this drug. So for congenital side effect knowing, the best study will be case control. And we cannot know it by cohort or RCT. So do remember all this question which has already been came in the previous exams. Let's come to this definition of PAR, RR and AR, which they frequently ask. Can you tell me the correct answer? What is the correct formula of PAR? Because we all think we know it, still we do the mistake. Can you tell me which is the correct formula of PAR out of A, B, C, D? See, relative risk simply means incidence in exposed by incidence in non-exposed. So when they use relative risk, they use the word time. In question, if they have used the question is like this, that ratio of incidence of exposed by incidence of non-exposed, or incidence in exposed compared by incidence of non-exposed is known as. So if this two language is used, that is relative risk. What is attributable risk? I hope you all know it is incidence in exposed minus incidence in non-exposed by incidence in exposed. So attributable risk only talk about exposed group, that out of exposed group, how many have the accident, how many don't have the accident. That is the attributable risk formula. And we multiplied by 100 to get the answer in percentage. And what is PAR? PAR is very simple to remember. All the places where you have exposed written, if you change it by population, AR become PAR. So PAR is incidence in population minus incidence in non-exposed by incidence in population multiply by 100. This is PAR. Let's take an example to understand it better. Let's say there are 100 people who are alcoholic, 100 people who are non-alcoholic, and out of these alcoholic, suppose 80 had accident, in non-alcoholic group 20 had accident. So the relative risk will be, in the alcoholic group 80 had accident, non-alcoholic 20. So relative risk will simply be 4. When it comes to attributable risk, and because both are 100 common, so they will cancel out and finally relative risk will come 4 times more. Attributable risk tell us that how many more accident occur in alcoholic. How many more? 80 here, 20 here. So 60 more accidents. 60 accidents are due to drink and drive. And this 60 is out of total population or out of exposed? This 60 is out of 80 alcoholic accident. So this attributable risk tell us the extra accident out of exposed, not out of total population. Whenever you find in the word question, in the question you found the word population, only then PAR will be the answer. And PAR tells us that if people stop drinking, then how many accident will decrease. So accident, if they find the word decrease by, that is PAR. Do remember that relative risk is the best indicator of strength of association. How strongly two things are related, RR tells best. And that's why RR is used by clinician, people sitting in OPD. AR, PAR are used by public health expert, and out of them, PAR is better way to give information because PAR talks in a positive way. So do remember this formula, and according to this formula, what is correct? Population minus incidence in non-exposed compared to population. So the correct answer will be C, will be the correct answer. So see, this was a confusing one. Okay. And you should remember it. And C. Now, which of these is not true? One of my friend Vaibhav Chaurasia is asking, का मास्टर साहब FMG के लिए ऐसा सेशन कब करेंगे? तो Vaibhav, I will do the session for FMG after 4 days. And so today is 21 and आज. So after 4 days, on 25th, I will have this session for FMG. Now, which of these is not true about randomization in a clinical trial? So when we do randomization, equal type of people go in the two group. It reduces confounding for sure. Confounder are external factors which are unequally distributed. So if you divide them equally by randomization, confounder will go away because confounder is always unequally distributed. It do decreases selection bias. Let me give you an example to make it better. Suppose you want to prove that OCP is, let's say you want to prove that OCP reduces breast cancer, and a company gave you money to prove it forcefully. So if you want to prove it, in the user group, OCP user group, you can take young people of, let's say, 20 to 30 years. And in the non-user of OCP group, you can take people between 40 to 50 years. And of course, in 20 to 30 years, there will be less breast cancer. It's not because of OCP, but it's because of the young age. So this young age is related to both exposure and outcome. OCP use is the exposure and less breast cancer is the outcome. So this young age is the confounder, because what is confounder? Confounder is something which is related to both exposure and outcome, and it is unequal in the two group. You can see it is unequal in the two group. One group are comparatively young, one group is comparatively old. So age is different now. That's why age is confounder, because it is different. So if you do randomization, you will ask them to choose chit, and those who choose chit A will get OCP. Those who choose chit B will not get OCP. And like that, you will distribute them. So when you are distributing them randomly, young and old will get mixed. And this effect of confounding young age will go away. Now, this is also selection bias example, because in one group we are selecting young people, one group we are selecting old people. So this is selection bias. And if you will do randomization, selection bias will go away. So this too will go away. And there will be comparability of the two group. The two group will be similar to each other, and therefore the internal validity will increase. Internal validity simply means how much the study is comparable. The two group are comparable from inside. So that will increase if we do randomization or matching. Randomization and matching make the study better from inside. But it does not increases external validity. External validity means generalization. Can you apply the result on general population or not? So to increase the external validity, we can include all the female between 20 to 60 year in the trial. Then the generalization will be better. So external validity is increased by generalizability. Internal validity is increased by randomization and matching. If the two group are comparable, study is correct from inside. That is the internal validity. Okay, so ensure comparability, that means internal validity increases, and randomization does not affect external validity. Now, all of the following are true about RCT except in RCT dropout are excluded. This is not necessary. See, if some people have side effect and they left your study, then it's not necessary that we will remove their data. There are two types of analysis. One is intention to treat. In intention to treat analysis, dropout data is also included. All patient data included. In final analysis, we include the data of all patients, that is intention to treat. But if it is per protocol analysis, in per protocol analysis, if someone have side effect or took outside drug, those patient, they did not follow protocol, so their data will be removed from final analysis. To remove this, to understand and remember these two things separately, we can understand it. Per protocol means perfect participant. Those who followed the command perfectly, did not took outside drug, did not have side effect, their data will only be included. Side effect or death data, death or outside drug, if patient took outside drug or died, it means they did not follow your command. So their data removed. Their data is removed in per protocol. But in intention to treat, all patient data is included. So we not always exclude dropout. Dropout are excluded from a study in per protocol analysis, but not in intention to treat analysis. That is why intention to treat is better for general public, because in intention to treat, we will also have death data. But per protocol analysis is better for researcher, because in this, if the patient died, we will remove their data. Because they are died means they are dropout. So dropout data is excluded, not in every RCT, only in per protocol analysis, we remove dropout data. Okay, do remember it. Now, in a survey of sleep apnea score among 10 people, highest sample was 58, but we wrongly written it as 85. So what will be the effect on the study? First thing is, if let's say the sample is 2, 3, 4, 5 and 58, and we are changing it to 2, 3, 4, 5 and 85. So in this case, in both the case, median is the middle number remains same. So median is no change. And if the last number we are increasing, then average will increase. Therefore, increase in mean will be there, but median will remain same. Okay. Now, this is a question based on quartile. In quartile, the first part is 25%. This is 75%. This is the box and whisker plot, which is used to represent this quartile thing. So they are saying that there are 200 people, 0 to 200. The first quartile or 25% is at 94 BP. The third quartile or 75% is at 110 BP. And how many patients have BP between first and third quartile? So first and third means how many patients are between 25% and 75%. This is first and third quartile. So between 25 and 75%, of course, 50% patients are there. And what is the 50% of 200? 100. So the answer will become 100. Sometimes they can ask how many people are more than third quartile or between third and fourth quartile. So between third and fourth, 25% people are there. So then the answer will become 50 because 25% of 200 is 50. If they ask how many are below first quartile means 25% people and 25% of 200 is 50. So answer will be 50. So in all such questions, first you have to look at the sample size, then divide the sample size into 4 equal parts, and then look at the question where they are asking. If they are asking between first and third, 50% will be the answer. If they are asking after third, 25%, before first, 25%, and like that you can answer. Now, interpret the following graph. Of course, the first one, if you see, we can draw a graph where 50% on both sides. So this one is normal. If you look at the second plot, in the second plot, this part, which is between 40 to 65, this part is skewed. Skewed का मतलब होता है खिंचा हुआ. This part is stretched. And we can very well understand that 40 to 75 is bigger number as compared to 25 to 40. So skewed part is towards bigger number. And because it is towards bigger number, and whenever in life, let's say you are going towards bigger number or bigger money, you are positively skewed. So if skewed part towards bigger number, we call it positive skewed curve. And in the other half, you can see in the third curve, the skewed part is towards lesser number. So lesser number, so we call it negative skewed curve. But bigger number, we call it positive skewed curve. And what are these dots on the outer side? These are outliers. Outliers means extreme value. So the correct sequence will be one normal, second positive, third negative, and normal with outlier is curve B. I was taking this class in Jaipur where a student told me a very golden rule which will never let you forget this box whisker plot thing. If they give you a curve with bar above, he said, take this bar as penis or thought of sex. If penis or thought of sex is in your mind all the time, you cannot concentrate on study and your marks will go negative. So this will be negative skewed curve. And if, let's say, this penis or thought of sex is below the belt, under your control, then you can concentrate better in study and you will go positive in life. So that will be positive skewed curve. So if the bar or thought of sex above, negative skewed. If the bar or thought of sex is under our control, positive skewed. Now I use the same concept to remember the formula of positive and negative likelihood ratio also. In both of them, there is sensitivity and specificity. But positive is when the bar is below, remember? So in positive, 1 minus will be below, positive likelihood ratio. Negative means bar or penis or thought of sex in the mind above. So negative will be 1 minus sensitivity. This way you can remember the formula also, and the skewed curve concept you will never confuse. Okay, remember bar above negative, bar below the belt under control, positive skewed curve. Now next question, in a diabetes patient, you want to explain the combined thing. What are the side effects and all of hypertension and diabetes together? Which plot will be used? So when we talk about hypertension, there can be heart attack, there can be stroke, there can be retinopathy, there can be nephropathy. Similarly, when we talk about diabetes mellitus, there can be cataract due to it, there can be retinopathy, nephropathy, and there can be peripheral neuropathy also with diabetes. So that means diabetes will lead to this many problem, hypertension will lead to this many problem. And this retinopathy, nephropathy is more likely to happen because this is the combined effect. So how can you explain the combined complication? Answer is Venn diagram. This is Venn diagram. Similarly, in one of the recent exam, they have asked which diagram is used to represent functioning of health system or reason of failure of health system, and a reason of good or bad functioning of health system. So if they ask reason to know the good or bad functioning of health system, the diagram that will be useful is fishbone diagram or Ishikawa diagram. This is a new way to represent qualitative data. Ishikawa or fishbone diagram. So in Ishikawa or fishbone, let's say we are talking about Indian health system, why it is failing. The first reason, of course, is that WHO say we need to give 2.5% GDP on health. This was a question. But how much India is giving for last 34 years? India is giving around 1.05% of GDP on health. And of course, no money, no honey. So our health system is performing less. Poor health system of India. Second reason is less number of rural hospital, PHC, sub-center and CHC, which is causing more death in referral. So poor health system. And a third reason can be poor patient to doctor ratio, especially in rural area, very less doctors are there. Fourth reason can be the contractual job, and they are only giving contractual jobs. So many of the aims are also vacant because we want permanent job to go and settle in rural area. So that's why many rural areas hospital are lost, not having doctors there. So this diagram will be fishbone or Ishikawa diagram. It's of course for qualitative data, categorical data. Now in a study, 2 groups of newborn are checked for their weight based on whether their mother received food supplement or not. Which test will be applied? When we are being given to tell about the test, first we should know which type of data is there. If the data is quantitative or measurable, for example, we can measure cholesterol, we can measure bilirubin, we can measure weight, height and all. In that case, quantitative data, if there is this word pre-post or match word, before giving drug, after giving drug, or match data, that means in one group 25-year person taken, other group also 25-year person taken. This 2 word if you found in the question, matched or pre-post, you will apply pair t-test, simple. If you found 2 group of participant in which quantitative data is taken, height, weight, BP, HB, in that case 2 group we will apply unpaired t-test, and unpaired t-test is also known as student t-test or independent t-test. But if there is quantitative data and there is, let's say there is 3 or more group, so then we will apply ANOVA, which is known as analysis of variance. So these 3 tests are for quantitative data, and usually these tests are parametric tests in which we apply Pearson correlation, P for Pearson, P for parametric. So Pearson is in parametric test, which is for large sample size uniform data. But when it is qualitative data, first thing is you have to identify which is qualitative. If I say my obesity, is it quantitative or qualitative? Obesity is my quality. It is mild. You can say कि मोटा तो थोड़ा मोटा है, बहुत मोटा या फटेगा. Mild, moderate, severe. You cannot say you are 3.8 obese. So you cannot measure it. You can only categorize it. Whatever we can categorize is qualitative. And all disease, if I say hypertension, hypertension is qualitative because it can be mild, moderate, severe. What we can measure is BP. So BP is quantitative, but hypertension, anemia, obesity, all are qualitative. Plus 2 more things from which question came. Median and mode, they are used for qualitative data. And qualitative data comes in percentage. So if you found percentage in question, median, mode or any disease name, directly answer chi-square test. Chi-square test is only applied if there is 2 or more than 2 group and there is qualitative data, we apply chi-square. So first thing you have to decide is whether it is qualitative or quantitative, and what they are measuring. This is the thing where we have to focus. What are they measuring here? They are measuring the weight. See, they are measuring weight based on whether their mother received food supplement or not. Received food supplement or not, it means there is two group. But what they are measuring is weight, and weight can be measurable. So if it is measurable, quantitative, and two group, which test we will apply? We will apply unpaired t-test, which is also known as a student t-test. But in the same question, if I say based on their mother received food or not, we are measuring whether the child is low birth weight or not. Suppose we are measuring percentage of low birth weight baby based on mother received food supplement or not. So low birth weight is a category. Either the child will be normal or low birth weight or very low birth weight. And there are two group, received food or not. Then the answer will be chi-square. And if we are measuring weight and there is three group, answer will become ANOVA. If we are measuring weight in any group, let's say you are measuring group of 100 people, you are giving a new drug to decrease obesity, and you are measuring their weight before giving medicine and after giving medicine, before, after, then answer will become paired t-test. Okay, so this simple way you can decide which test to apply. Remember, qualitative data, chi-square. Pre, post, before, after match written, paired. Two group quantitative, unpaired. Three group quantitative, ANOVA. Okay. Now let's do this question. Which of the following is used to compare two data set taken on two different scale of measurement? That means they are comparing quality of two data set. This is done by coefficient of variation, which is the standard deviation by mean. Coefficient of variation is used for two purposes. It is used to compare quality of data, two different quality. Measure in different unit also we can compare them. Compare quality of data, and it can also compare dispersion in data, which data is more dispersed. For example, let's say you are comparing NEET and INICT score of a student. Of course, of any coaching institute, you are measuring the NEET score and you are comparing it with INICT score. So NEET and INICT score are, the numbers are different, negative marking is different, they are totally different. How you can compare it? You can compare you can measure coefficient of variance of NEET score with coefficient of variance of INICT score, and you can compare these two data even if their unit is different. So quality of data, dispersion of data, by variation we compare it. All of the following cause widening of confidence interval except. See, when we increase sample size, range of confidence interval decreases, and a smaller confidence interval or a smaller coefficient of variance means better quality data. This two question has been asked already, so do understand them separately. Let's say I ask this question from a final year student, that how much correct question they will do out of 200. He can say I will do between 150 to 160. And I will ask how much sure you are. He will say I am 95% sure. So this is 95% confidence interval, 150 to 160 in final year student. But if I ask the same question from first year student, he will say, sir, I will score one question to 200 question correct. I am 95% sure about it. So this 1 to 200 is a confidence interval range, which is not giving us any idea whether first year will pass or fail. So this type of confidence interval with big range is non-significant, useless data. And the small confidence interval is more significant. Now, why it is more significant? How it made more significant? Because final year student has done many PYQs of last year, so given some GTs, and again they are getting a score between 150 to 160. That's why this final year is more sure now. So how he made it sure? By increasing sample size. Because he is doing observation again and again, solving PYQ again and again, therefore the expected marks range is becoming narrow. So by repeating sample size, increasing sample size, there is not widening but narrowing of confidence interval. And we want big things in life. Remember this. We want big things in life, but two things starting with C, confidence interval and coefficient of variance, they should be smaller. The smaller, the better. Okay. Now, if we say that there is no significant association between two variables, but truly the association exists. We are saying that there is no association, our study is useless. And a researcher said, study non-significant, useless. But in reality, what is happening? In reality, there is an association. In reality, study is significant. It means researcher is underestimating the study. Because researcher is saying that the study is null, but actually it is useful. This type of error is beta error. Do remember, beta error is type 2 error, and beta error is when we underestimate ourselves or underestimate any study result, then we do beta error. And the opposite is true, alpha error. So beta error, simply you can understand it as false negative. False negative is beta error. And alpha error, which has the same meaning as p-value. Alpha error, p-value, they both have same meaning. What is the meaning of alpha error? Alpha error and p-value both mean false positive. A lot of questions come on this thing. False positive is the meaning of alpha error, p-value. See, when it comes to the definition, p-value simply means probability of getting significant result by chance, and a significant result by mistake or by chance. That is p-value. Like I still remember my first day of college, there was a good girl, Monica. She was looking at me, and I thought, by her one look, I thought that this is the college, this is my life settled, and I thought it is significant, and I was jumping the whole day. But when I went back to my room, I came to know that other friends of my class also have the same misconception. So what was happening on that day? We were getting significant result. We were getting our butterfly coming out, but it was just by chance, by mistake. So that means p-value is an error now. And whenever there is an error, we want to keep it minimum. So that's why the p-value should be less than or equal to 0.5. Less than or equal to 0.05 or 5%. Because if there is less than 5% mistake, then we say that study is significant. And when a study is significant, we reject null hypothesis. Okay. So the mistake should be minimum. It should be less than or equal to 5%. Then we say study significant, null hypothesis rejected. Why we say so? Because alpha error, p-value have same meaning, false positive, saying non-significant as significant. That is alpha error. That is p-value, non-significant as significant. And a very good example of this is coronal study by Baba Ramdev. He did the study on people without symptom, without fever, and said coronal can treat fever. So he did a non-significant study and said that it is significant forcefully. That is alpha error, and he is giving a false positive report to the coronal. And see, in the p-values, same thing is happening. What is happening in Baba Ramdev study? He was getting a significant result for coronal, but he was getting it by chance, by mistake. So significant result by chance, that is p-value, that is alpha error. And a false positive is p-value, alpha error. And we pre-decide alpha error. The pre-decided alpha error is 5%. Up to 5% time, if we are giving false positive report, it's okay, accepted. So we pre-decide alpha error 5%. And let's say you are going to an exam of NEET, let's say, and you thought I will do 5% mistake. And you actually did. So this was your alpha error 5%, which you pre-decided. And you actually did just 5% mistake or 2% mistake. And so your p-value is less than or equal to 5%, and only 5% mistake you did. So if you did only 5% mistake in NEET exam, then your result will be significant now, because you did very less mistake, only 5% mistake. But let's say you pre-decided that I will do 5% mistake, but actually you did 20% mistake. So do remember this point, if our p-value is less than alpha error or equal to it, then we say result is significant. But if our p-value is coming 20%, if p-value is coming more than alpha error, then if we did this many mistake, then result become non-significant. So that means our p-value should always be less than alpha error or equal to it for significant result. And that's why we take the cutoff as 5%, because alpha error is pre-decided as 5%. And therefore, whenever p-value is less than or equal to 5%, result is significant. Okay. So do remember, alpha error p-value both means false positive. And at any time, if p-value is less than alpha error or equal to it, then our result is significant. And do remember this line, that whenever p-value is 0.05 or less than that, then null hypothesis is rejected and study is significant. So this type of error is type 2, which was in the question. Now let's come to the next question. If the level of confidence is increased, what happened to the level of significance? Level of significance is, in a way, you can call it as p-value. So if level of confidence, see, there is a concept that confidence of a study is equal to 1 minus alpha error. Like if I ask how much confidence you have on your friend, it all depends ki how much lie your friend say, aapka dost feekta kitna hai. If there is a lot of lie, lot of alpha error, confidence will be less. So this is the confidence of a study. It's not same as confidence interval. If the level of confidence is increased, suppose I am increasing the level of confidence. If I am increasing the level of confidence, it means I am decreasing alpha error. So if the level of confidence is increased, first thing is alpha error decreases. Now, as I said, if alpha error is more than or equal to p-value, then we say study significant. You pre-decided I will do 5% mistake in exam. If your exam error is just 5% or less, then your study result will be significant. So here, when we increase confidence, on increasing confidence, alpha error is less. Alpha error is less means, let's say alpha error changes from 5% to 2%. Okay. Now, because alpha error has become 2%, the p-value which was coming 5% and study was becoming significant, if p-value is still 5%, now you can see p-value become more than alpha error. And whenever p-value is more than alpha error, in that case, study is non-significant. So, if I increase the confidence, on increasing confidence, first thing is alpha error reduces. And if alpha error reduces from 5 to 2%, previously significant study become non-significant. Okay. So, based on this concept, what will happen if I increase the level of confidence, alpha error is less, and when alpha error is less, then significant study can become non-significant. So the correct answer will be significant value become non-significant. Okay. I hope this concept is clear. Coming to the next question, the mean systolic BP was measured in a sample of population of elderly female and it came out to be 125, standard deviation of 10. 95% of people would have BP above what? We all must know the confidence formula for 68% confidence interval, which is mean plus minus 1 standard deviation, and 95% confidence interval also, which is mean plus minus 2 standard deviation. So if you find 95% confidence interval, mean here is 125, standard deviation is 10. So 2 into 10 if you will do, it will come 105 to 145. But you can see 145 is not in the answer. They are asking 95% people will have blood pressure above what level? Above what level? So that means in this question, let's draw this thing and understand it better. This is the confidence interval for BP. minus 2 standard deviation is at 105, plus 2 standard deviation is at 145. How many people are outside plus 2 standard deviation? Outside plus 2 can only be 2.5% people, and below 105 also only 2.5%. Why? Because we all know between minus and plus 2, 95% people lie. So if 95% are inside, subtract 95 from 100, how much are left? 5 are left. And those 5 cannot be in one side. They will be divided 2.5, 2.5 on both sides. So that means below 145, not 95% people are there, but you can see this 95 and this 2.5. Total 97.5% people are below 145. And in the exam, they are asking how many 95% people are below what BP. So to find 95% people, you have to go a bit inside. If you go a bit inside from 145, let's say till 140, 140, you can have 2.5% people between 140 to 145. And finally, how many people are outside 140? 2.5 plus 2.5, 5% people are outside 140. So how many people are below 140? 95%. So that means when they ask 95% population, 95% population is just below upper limit of plus 2 standard deviation. Plus 2 standard deviation is at 145, just below 145. What is the answer? 140. So below 140, 95% people will be there. Similarly, sometimes they ask where is 5% people? 5% people just above minus 2 standard deviation. And that means whenever they ask 5% or 95%, it is between plus minus 2 standard deviation. And so when they ask 95%, you have to go a bit down 145. If they ask where are 5% people, so 5% people will be at around 110, because 2.5 are below 105, 2.5 more are here, so total 5% are below 110. That means 5% is at 110 and 95% is at 140, and you can see 140, 110 are both in between plus minus 2 confidence interval. In between 105 and 145, 110 and 140 lie. So whenever they ask 5%, go just above minus 2. Whenever they ask 95%, go just below plus 2 standard deviation, and you will get the answer. Okay. Now, next question. If sensitivity is 98%, it means we are including almost everyone. Whoever has the disease is included. Now, if someone have negative report, it means that person is truly without disease. It means the patient is less likely to have the disease. Because sensitivity is 98, we are including almost everyone. If anyone now come negative, he must not have the disease. Okay. Positive predictive value depend on 3 things. It depends on sensitivity, specificity, and prevalence. Multiple time asked, PPV depend on prevalence. Now, in such type of test, they can give you the table and ask sensitivity, specificity, and under exam pressure we do forget the formula of sensitivity, specificity, but it's very simple to remember. We all know sensitivity is true positive. Now in the denominator there is again true positive and just opposite of that. What is the opposite of true? False. What is the opposite of positive? Negative. So the formula will be true positive by true positive plus false negative. And in specificity, we just remember the numerator is true negative. Again, with the same help, you can remember the formula of specificity forever. In the denominator of specificity, there will be true negative and just opposite of that. What is the opposite of true? False. What is the opposite of negative? Positive. So if you just remember the numerator and then the just opposite will be in the denominator, you will never forget the formula. We all know specificity, this two part, they together make non-disease. So specificity is true negative by non-disease, and we can multiply by 100 if we want to get the answer in percentage. But sensitivity is, as we all know, true positive by disease into 100. Okay. So now let's find sensitivity, specificity. See, in this table, they have turned the table in the wrong side. And usually disease and non-disease are written above. But here they are writing test positive, negative above. Even if they turn the table in any way, always remember that this part will have true positive And this part, above part will have true positive and this part will have true negative. That never changes. Now, what is the formula of specificity? True negative by non-disease into 100. How many are true negative? 95 are true negative. How many are without disease? 95 plus 5, 100 are without disease. So 95 into 100 if you do, 100 will cancel out and finally specificity will come out 95%, which is only in two options. So either A will be correct or D will be correct. Now let's find sensitivity. As I said, sensitivity is, and you all know also, sensitivity is true positive by disease. Into 100 if you want to get answer in percentage. So what is the true positive here? 27. How many are disease? 27 plus 3, 30 are disease. So 27 by 30 into 100 if you do, it will come 9 by 10 into 100 or 90%. So correct answer is option A, sensitivity 90, specificity 95%. Now, let's do this type of question where they confuse you by test positive, negative and big story. But it's nothing to confuse. If you just concentrate, you will be able to answer it. In a histopathological confirmation of ovarian cancer, a cohort, there was 60 out of 100 who tested positive. But actually had ovarian cancer is in 60 people. 60 out of 100 who were tested positive with this test actually had ovarian cancer. Actually had ovarian cancer means this 60 are true positive. And total 100 came positive. 100 is the total positive. We all know total positive has true positive plus false positive. We already know true positive are 60, total positive are 100. So how many are false positive? False positive will be 40. We can find false positive from here. Now, next step is out of 20, 100, out of 100, 20 female who tested negative had ovarian cancer. So 100 is the total negative. And in the total negative, there are two things, true negative and false negative. False negative means miss out. Miss out means जिनको बीमारी था और पकड़े नहीं गए, those who had the disease but they were not caught. And this is written that 20 out of 100 had the disease but wrongly came negative. So false negative is given 20 and total is given 100. That means true negative is 80. Now they are asking NPV, the formula of NPV, I hope you all know, it has everything negative. True negative by true negative plus false negative. So true negative here is 80 and total negative are 80 plus 200, 100 into 100 if you do, it will come 80 by 100, or if you turn it into percentage, 80%. So NPV will be 80%. So you should know how to deduct the meaning of that thing through this formula. In a HIV positive mother, what is the management which we give to the child? Irrespective of the report of the child, in the beginning, we always start with nevirapine and we give it for 6 weeks only because nevirapine is hepatotoxic. Then we give two drugs, lamivudine plus zidovudine, from 6 weeks to 6 months. So these 3 drugs are given till 6 months, and then we do HIV DNA PCR test at 3 months of age. 6 weeks and 3 months we do. If it came negative, we stop it after 6 months. Till 6 months, this usual treatment is given, nevirapine plus lamivudine plus zidovudine. And if the infant is unable to have increase in CD4 count with this 3 drug, then we can add raltegravir. Can be added if needed, not necessarily. So what are the drug we give? Replacement feeding is not needed. Give nevirapine even if the baby is negative. Even if negative, we will give nevirapine. Nevirapine is given for sure till 6 weeks. Then at 6 weeks we do the test and then we decide whether to give lamivudine, zidovudine or not. But usually till 6 months we give these 3 drugs: nevirapine, lamivudine, zidovudine. Now, in adult, what are the 3 drugs we give? Very easy to remember. Limited edition, lamivudine, tenofovir, dolutegravir. And in children, we cannot give tough drug. So in children, tough is received by abacavir. And LAD become the drug for children and limited become the drug for adult. Do remember, dolutegravir is affected by rifampicin. So if TB and HIV drug are given together, we should increase the concentration of dolutegravir. HIV sentinel surveillance is done to know the trend of HIV in different state, whether HIV is decreasing or not. And in HIV sentinel surveillance, we don't include STD patient. We do HIV sentinel surveillance on 4 high-risk group people, which are sex worker, transgender, IV drug user, and MSM, male having sex with male, 2 breach population, migratory worker, long-distance truck driver, and 1 mother. But we don't do it on STD patient. STD patient will go to Suraksha clinic, which will have this type of logo, and this logo with center, that is Suraksha clinic, which is also example of public-private partnership. And do remember, in every public-private partnership, drug always from government. They have asked this question, that in mobile medical unit and Suraksha clinic, who give the drug? Drug always come from government. Now, screening under NTEP, if you have to do the screening is done by sputum microscopy, Jaden smear in a large population but this is screening for cases. If I am doing screening for spread of TB, for spread of TB means we are talking about infection, and infection is detected by tuberculin test. Tuberculin and IgRA, 2 things tell about infection, out of which IgRA is better but more costly. So screening for spread is done by tuberculin test, but screening for case is done by Jaden smear. Now, do remember, in which TB investigation we take whole blood sample? IgRA is the only in which we take whole blood sample. If they say, in case of HIV, diabetes mellitus, COVID, pediatric TB suspect, and previously treated TB, what is the first test which we do? Jaden smear or CBNAT? In these 5, we directly do PCR or CBNAT. In these 5, no need of doing Jaden smear. Okay. And if they ask what is the gold standard for TB diagnosis, gold standard is not CBNAT, because sometimes it overdiagnosed. Gold standard is culture in liquid medium. Okay. So this 3-4 question come from screening. Do remember them. Also, there are 5 questions which come from image of mother and child together. Do remember, if mother and child are in the image and it is black color mother child, it is Lux program, which is for improvement of facility in labor room, maternity ward, and maternity OT. If it is white color mother child, it is foreigner program, baby friendly hospital initiative, in which prevention of infection is not a priority. If it is green color mother, green color child, I discussed it, Anmol program, ANM tablet based software for data entry and follow up. If it is blue color mother, blue color child, it is UNICEF. And if it is incomplete mother, incomplete child, it's an incomplete program, PM Matru Vandana Yojana, in which previously 5,000 are given, but now 6,000 rupees is given. First 2,000 at 12-week registration, next 2,000 at 6 month, and last 2,000 after 6 weeks of delivery when mother comes for vaccination. So these are 5 programs in which mother and child are together. Plus, they can ask you this thing that which of the following are larval control measure except? So DDT is used for adult, not for larva, and Rextol, Gambusia, Face, Paris Green, and intermittent irrigation can use for larva. Intermittent irrigation is best rural malaria control strategy. Okay. Now, DDT is after 6 months we need to respray, but for malathion we need to respray after 3 months. Do remember it. One more thing I want to tell before ending this session is that under JSY, they are doing many things. First thing is the cash benefit given to mother and ASA. Second thing is safe abortion services. Fourth is the Vande Mataram program, in which private doctor will keep the logo of Vande Mataram and will be given all the things which ASA is distributing. Fourth thing in JSY is follow up of high risk pregnancy by Anmol ANM software. Fifth thing is maternal death reporting and death reporting or autopsy and verbal autopsy to know the cause, maternal death review. And the last thing under JSY they are doing is they are doing village nutrition day once in a month. So these are the sixth thing which are done under JSY. Okay. Now, under NSSK, Navjat Sishu Suraksha Karyakram, there are 4 things which is done. First thing is prevention of infection. Second thing is prevention of hypothermia. So if you prevented the child from hypothermia or infection, then you will do breastfeeding, exclusive breastfeeding. This is the third thing. And if you are unable to prevent, then you will do neonatal resuscitation. So that is the fourth thing. So do remember what are the things that they are doing under these programs they ask. Okay. So that's all from today's session. And there is of course a lot to discuss, but these are some of the PYQs and related topic which I am expecting to come in your upcoming NEET exam. So we will meet again. Till then, hasta la vista, tasvidania. Thank you so much. Bye bye. Thank you, my friend, for replying so well. Harsh Kasliwal, Vaibhav Charasya, Dr. Starry Sky, To Light Love. Thank you so much for such firm reply. I was unable to look properly at your reply because I was willing to finish it in short time. Thank you so much. Enjoy your time. Be positive for exam. And in your last day, just do the PYQs and go with a positive mindset after taking blessing from your mother at least. And I have my blessing with you. All the best. Thank you so much. Hasta la vista. Das vidania. Bye bye.